Let's go. Thank you very much for inviting you today and to let us share with you, our French model in care in France for our prenatal psychiatric care. In first part, Professor Anne-Laure Sutter-Dallet, our pioneer in perinatal psychiatry in France, will present the general information concerning the organization of perinatal psychiatric care in France. After, our past president, Dr. Ludivine Guérin, will present us mother-baby unit model in maternity wards. After, we have the Professor Florence Gressier, who will present us a model of mother-baby unit in a general hospital. After, Dr. Antonia Mezzacapa will present a mobile team model in perinatal psychiatry in maternity wards. And it's a big deal. If we've got enough time, I will present a model of day hospital units in Poitiers. And we'll see depending on your questions and of the time we get. Okay. So to save time, Anne-Laure, I let you take the floor.
Thank you very much. I just share my screen now. It's okay for everyone?
Yes, thank you, Anne-Laure.
So, as Charlotte said, thank you very much for giving the Marcé Francophone Regional Group the opportunity to present the new organization of perinatal psychiatric care in France. It works for you? Yes. Following the COVID-19 pandemic, the Ministry of Health of France set up a national committee on psychiatry tasked with making recommendations to improve psychiatric care, and among its objectives was perinatal psychiatry, and I was fortunate enough to be one of the two coordinators of this issue with my colleague Michel Dunia. We, of course, based our work on scientific research, but also on the UK Bauer report that you probably know already about the cost of perinatal psychiatric care. And this report made by the London School of Economics showed that more than 70% of these costs in perinatal psychiatry are related to child development disorders in the context of parental mental illness, but above all, that good organization of care costs 5 times less in the long term than doing nothing. We were also inspired by the ideas that some of us had developed under the coordination of Marie-Paul Austin, which we had set out in a statement issued by the Marcé Society in 2013. And that statement underlined the value of combining assessment of both physical and emotional health of women during the perinatal period because of the impact of psychosocial morbidity on the transition to parenthood and infant attachment and development. Thus, we recommended in this statement universal psychosocial assessment combining systematic evaluation of the psychosocial context and risk factors and systematic detection of possible current disorders. And I think you can find the statement on the website of the Marcé Society. Thus, the overall objective set by our committee was to be able to integrate into usual perinatal care and to propose care pathways ranging from positive mental health to serious psychiatric disorders, including psychological distress, which are very common in the perinatal period. Indeed, we all know that during this period of life, extremely serious conditions can arise very abruptly, putting the lives of both mother and child at risk, but also that these episodes can be resolved by very quick treatment. In that respect, it was necessary to consider all the specific dimensions of perinatal psychiatry, the first being the need to treat two intertwined and interconnected human beings for whom the same care can have different effects. We therefore also had to consider designing the pathways in such a way that they inherently incorporate continuity of care from the antenatal to the postnatal period. Our pathways also had to consider the two types of patients with a history of mental illness, for whom we had to develop secondary prevention measures with a special focus on multidisciplinary preconception consultation. And on the other hand, we had to be able to respond to a primary prevention approach for the general population, and therefore put in place screening measures mainly during maternity stays. Of course, we couldn't forget the father, the family, and the environment. So we had to respond to every situation and every question and every aspect represented in this diagram, which is a lot. I might as well tell you that when the psychiatrist, the child psychiatrist, the obstetrician, the pediatrician, the social worker, and the family have to agree on a care plan, we sometimes witnessed rugby scrums where everyone had a perfectly legitimate point of view from their perspective, but which did not correspond to that of the other professionals. And this is one of the key issues that remains only partially resolved today in France, namely coordination at all levels, but we will come back to that later. Our committee therefore proposed a draft bill in 2022, which was fully adopted by the Ministry of Health. It was based on a graduated system of care at regional level, knowing that we have 13 regions in France. This graduated system is organized around full-time inpatient units that serve as resource and expert centers and coordinates with daycare units, mobile teams, and specialist consultation centers within their geographical territory to provide care pathways tailored to each individual situation. These cares also have to be integrated into standard perinatal care through medical, psychological, and social staffs implemented in maternity wards. These staffs bring together obstetrician, pediatrician, and social worker and postnatal care teams to discuss the management of the most complex cases. All this work obviously need to be coordinated, as I said before, which is probably the most complicated part of our work in progress. All this work led to the inclusion in the French Public Health Code of Perinatal Psychiatry and two major administrative developments. The first was the requirement for hospitals to obtain specific authorization to practice perinatal psychiatry with legal obligations in terms of structures, teams, and access to this care. And the second is the introduction of a specific medical billing code for joint care procedures. The benefits of a specific pricing that takes into account the presence of at least two people involved in the care over the same time period, namely the baby and at least one of its parents, is to obtain double pricing for each treated dyad, one for the parent and one for the baby, which therefore doubles the profitability. On this last subject, thanks so much to the determination of the Dr. Renelli, among others, who worked very hard on that. As for the French-speaking Marcé, our website features a map. It is not perfect, some are missing now, but we will go on with that. And this map helps patients and healthcare professionals to find the most suitable healthcare facility closest to their home. You simply enter on the left side, you can see that the region and the type of structure that you are looking for, and we provide you with the address and the telephone number and so on. It's the most visited page of our website. So thank you for your attention, and my colleagues will now give you some example on how various joint care arrangements works in France actually. Thank you.
Thank you very much, Anne-Laure, for your presentation. Ludivine, it's your turn for a model of mother-baby unit in the maternity wards. Are you ready?
Yes.
Let's go. Can you share your screen?
Can you tell me if it's okay?
That's fine.
Okay. So, nice to meet you. First, I apologize for my terrible English, please. In Toulouse, in France, we have since 1 year a parent-baby joint care, which is an integrative model of perinatal psychiatric unit in a maternity department. This is a full-time hospitalization for mothers and babies and even fathers from birth to 1 month of life for the baby. And we, in the same unit, we provide perinatal psychiatric care and obstetrician and pediatric cares. This is our teams, and you can see 3 midwives and 2 nurses. Every day there is 1 midwife and 1 nurse, even the weekend, which take care of the family. And there is a perinatal mental health team too, at psychomotor therapist, psychologist, social worker, and child psychiatrist. We work in close collaboration with obstetricians, pediatricians, and maternity head nurse. We can take care of 5 families, and we offer a prenatal visit and the opportunity to meet the team before the birth. So families can be referred before childbirth when parents have psychiatric disorders. And we have a pre-admission consultation. Then admissions is after childbirth for parents and baby together. But sometimes we can admit parents and baby after birth. They are addressed from maternity other wards or from other hospital in the city and even from other departments. This is the indications. We can say all situations with parental psychiatric disorders or psychologist difficulties, which can affect the early relationships between parents and baby. But all admissions required parental assessment. So if parents need for adult psychiatric hospitalization in emergency, and especially involuntary psychiatric care, or if baby require pediatric admission, we can't admit the family. If baby is older than 1 month, we can't. And when parent-infant interaction are unsafe for the baby too. We don't accept family with assessment only and no care plan or social need only. So, which sort of parents-baby joint care? Sometimes we provide in-room daily care with individualized physical care and support for early interaction between parents and baby, for bathing, feeding, breastfeeding, daily routines. We provide psychologist care, individual consultation for the mother, for the father, with baby or not, for the couple. And we propose psychophysical care for the family, alone or in group. We propose different workshops and group therapy called, for example, Understanding My Baby, Parental Emotions, Lullabies, Needs for My Baby, Advice Before Going Back Home. But all therapies are realized with two professionals. For example, one psychologist and one midwife, or one nurse and one psychiatric, or etc. And we have a strong multidisciplinary coordinations for a good quality of integrative care. So we need a lot of time of coordination and meetings. This is our shared room for the group therapies and workshop and for coordination meetings. In our unit, Care en Mater, instead of the other unit of the maternity, we worked for specific adaptations. For example, co-parents may stay night and day for free. And when there is a long hospitalization, we help the father to ask a flexible paternity leave. We open medical file for both parents and for the baby, and brother and sister and extended family like grandparents are included when relevant. We try to respect the most of possible for the rhythm for parents and baby. For example, meals only when they ask, and we try to do not wake up babies and parents for medical appointments. And we try, we even try to have a very good consistency in childcare advice and guidance. Before discharge, and especially for family who have a lot of problems, we organize a multidisciplinary staff meetings and to discuss about continuity of care for parental mental health, infant development, and joint care. And before final discharge, we propose to parents workshop about community research provide and supervise first, and we try to supervise the first outings with baby, and we propose a progressive transition to go back home. We have a role in regional coordination and research, telephone support and orientation for professionals, participation in training programs, and research involvement. We propose to the families assessment tools like a PDS when entry and where they live, parent-infant bonding tool, and NBO. This is 1 year results because our unit opened last year in March. We admit 117 families, and you see a lot of fathers were present during the hospitalization. The average stage is very short, 12 days, but minimum 5 and maximum 28. And in 4 situations, we had to transfer the mother in adult psychiatry unit, and we could keep baby and father with us in the maternity. And for 6 situations, we had to require child protection measure, and 4 babies were placed in care before the end of the hospitalization because of a danger for them. This is our maternal's profiles. You can see a lot of borderline personality disorders, but also anxiety disorders or depression during pregnancy, and bipolar and psychotic disorders or complex PTSD in the most of the case. In the majority of the situation, parents and baby come back home, and a lot of family needs to have care after parents baby home care units or parents baby daycare units, and sometimes only outpatients follow-up. We can see that the impact for the babies are especially early symptom detection and faster intervention for development treatment. And for the parents, an early identification of decompensation, and they tell us a very positive experience of bonding support. And for the interactions between parents and baby, we try for the parents in difficulty to recognize their baby earlier as a person. So we propose early integrative perinatal care with strong parent-infant focus and a multidisciplinary approach. And we think there is a positive clinical and relational outcomes. Thank you very much for your attention.
Thank you very much, Ludivine. It was really interesting. It's your turn, Florence. Are you ready? Bravo. Thank you, thank you.
I'm going to try to share.
Yes, ça arrive.
Alors, attends.
We are in time.
OK.
Alors, on ne voit pas ton écran, Florence. Tu as partagé là? Ouais. Super.
Normalement.
Tu l'ouvres? Ouais, super. On voit que tu ouvres ton diaporama à partir du début. Fine.
It's okay, but I've lost the camera, so I know. I hope.
But we are
Okay.
ready.
Okay, so first of all, I would like to thank you for inviting me to give a talk in these sessions. And what I'm going to do today is to speak about a full-time mother-baby unit hospitalization model. And I have no conflict of interest. So I will start with this sentence from the NICE. Women who need inpatient care for mental disorders within 12 months of childbirth should normally be admitted to a specialized mother and baby unit unless there are specific reasons for not doing so. As you know, there is a long tradition of perinatal psychiatry in France. In 1858, Marcé described perinatal psychiatry, maternal psychopathology, and in the UK, Men in 1958 reported the twin dangers of separating mother and child. How can a woman become a mother if her baby is not physically present? And how can a baby become attached to his mother if it is not the mother who is providing his daily care? Racamier in France in 1961 occasionally admitted mothers and their babies to an adult psychiatry department. As you know, the first mother and baby unit opened in the UK at the Banff State Hospital in 1959. And in France, it was about 20 years later. The first mother and baby unit opened in 1969 in Créteil in a department of child psychiatry. and in Villejuif in 1980 in a department of adult psychiatry. And as you know, in Australia, it was about 1980. So what are full-time psychiatric mother and baby units? They are specialized inpatient care units where mothers with mental health disorders are admitted with their baby. The objectives are to provide care for psychiatric disorders in women and to facilitate mother-child interactions and bondings. There is a multidisciplinary staff which is trained and dedicated to the unit, and the location ensures the safety of both mothers and child. So what about mother and baby unit in France? There are 17 inpatient psychiatric mother and baby units in France, and most are attached to public hospitals. They have different settings, separate buildings, as part of a larger unit of psychiatry or near a maternity ward. They have about 3 to 8 beds, and as you can see on the map, there are significant geographical disparities. So now I'm going to present the perinatal psychiatry at Bicêtre University Hospital. It's a part of the adult psychiatry department, and it was established in 2012 by Professor Patrick Hardy and myself. So it comprised outpatient consultations, also liaison services, and a full-time mother and baby unit with a capacity for 6 DIADs. And approximately 40 DIADs are hospitalized each year. Which are the indications? The indications are first acute episode or chronic disorder. It can be severe psychiatric disorder like postpartum psychosis, manic disorder, major depressive episodes, schizophrenia, chronic psychosis, or personality disorders. It could be also problems of interactions between mother and child. What about baby age? It's from birth, around 3 days of life, till 1 year. And the mean age in her cohort is about 2.5 months. There are no involuntary admissions. What about referrals? Referrals are Bicêtre hospitals in 49% of cases, emergency in 11%, some psychiatric consultation maternity wards from Bicêtre University Hospital in about 38%. Also, women come from other psychiatric hospitals in about 19%, and it could be outpatient from mental health centers in about 5%, and outpatient from liberal psychiatrists in about 8%. In the less, it could be social services, it's about 3%, and women come from other maternity wards in about 16%. So what about admissions? The maternal age is about 31 years old, and main maternal diagnosis, as you can see, it could be a postpartum depression, a first episode in only 8% of cases. It's almost recurrent depression in about 46%. It could be also bipolar disorder in 12%, postpartum psychosis without another diagnosis in 9%, chronic psychosis in about 15%. It could be also for the main diagnosis, personality disorder in about 3%, and substance abuse disorder in 3%, and anxiety disorder in about 4%. It is only the main diagnosis, and of course, we could have also comorbidities. So what are the expertise? The main expertises are to treat women with psychiatric disorders while admitting her baby, avoiding unnecessary separation. Also to ensure child care and development, to prevent the impact of maternal disorders on the baby, providing support and assistance in the care of the baby. Also to facilitate and enhance mother-infant interactions, supporting the mother-baby relationship in a multidisciplinary management. The perinatal psychiatry in Bicêtre hospitals is secured with a locked door and security cameras to ensure the baby's safety. And as you can see on the picture, each mother has her own room to sleep and rest in. And the 6 babies sleep in a nursery. They also have the diner in the dining room for the mother and also the babies. So first of all, there is a pre-admission visit. It's a multidisciplinary consultations to assess mother psychiatric conditions, infant's development, but also mother-infant interactions and social difficulties, and also co-parents' medical conditions. The team describes how the department operates and gives a tour of the unit. So if possible, it's really important that the co-parent or a family member be there. And you can see on the picture the place for pre-admissions, which is in fact in the activities room. So who works in the mother and baby unit? There is a multidisciplinary staff. And now Antonia Mezzacapa is at the head of perinatal psychiatry. So there is a multidisciplinary staff with a perinatal psychiatrist, a pediatrician, 1 day a week, mental health nurses, 1 during the day and 1 during the night, also nursery nurses from about 9 a.m. to about 4 p.m., 1 during the day. The team has also nursing auxiliaries and childcare assistants, 1 during the night and 1 during the day. Also, there is a psychomotrician's half-time, psychologist, 1 for all the department, occupational therapy, she does a group twice a week, also a social worker, 1 for the department, and students in training. And you can see on the picture the nursing station also in the mother and baby unit. So what about daily care? The mother has a daily consultation with the psychiatrist, and psychotropic medications are adjusted daily. The mother can also have consultations with a psychologist. She receives supports in all her activities with her baby, 24 hours a day, including bathing, changing, and feeding the baby. And you can see on picture the changing room with bath tube and table changing. If the woman is unable to care for her baby, the team does so. Babies are also examined by the pediatricians 1 a week, and groups are organized for mothers, such as occupational therapy sessions, psychomotor sessions, and also for mothers and their baby, such as psychomotor sessions, bonding sessions, and baby message sessions. So, as you know, hospitalization can be unsettling for fathers and the family. Often, they have had to step in for the mother when she was unable to be there, either physically or emotionally. So the mother and baby unit must support co-parents in the family because it can be hard to have the babies and the mother hospitalized. So the mother and baby unit has to help men how to father. Also to encourage father to care of the baby. And the team has interventions with the mother, the father, and the child. Also, we developed father's group to help the father to support the mother, but also to early detect postpartum depression in father. As you know, postpartum depression occurs about in 10%, but if the mother is hospitalized or depressed, the rates is really higher. So we can also offer psychotherapy and, if needed, antidepressant for postpartum depression in father. So what about discharge for mother and baby unit? The length of stay is about 6 weeks, and it's important to have a multidisciplinary management, working closely with specialist community perinatal mental health teams and other providers in primary, secondary, and social care to encourage timely discharge. In the cohort, the improvement for mothers is about 90%. They return home or to a care facility in 92%. Of course, it could be psychiatric hospitalization without the baby in about 6%, and also another mother and baby unit in about 2%. In the cohort, mother-baby interactions were good or improved in about 90%, and mother-child separations occurs in 10%. 6% of the babies go in institution and 4% with family members at discharge. So, as a conclusion, mother and baby unit need a multidisciplinary management, and it's important to support the father, the child, and the mother. A mother and baby unit must be linked to familial, social, and medical resources, and it's a priority to work with psychiatrists, pedopsychiatrists, obstetricians, midwives, pediatricians, and social workers. So mother and baby unit should be part of a health perinatal network, including maternity wards, neonatal care, and community resources. I thank you for your attention.
Thank you very much, Florence. It was very clear. Thank you. Thank you. Thank you. Antonia, are you ready now?
Yes, of course.
Nice. And the time is very good.
Florence doit interrompre sa connexion pour que j'aie accès au partage.
Oui, je sais, mais j'ai toujours le même problème, j'y arrive pas.
Ok.
C'est pour ça que vous m'avez pas vu tout à l'heure non plus. Je sais pas si quelqu'un peut arrêter le partage.
Tu peux le faire, ok.
Super, c'est bon.
Ma vediamo dal mio con le note. Ecco. Ok. I will present you the liaison perinatal psychiatry team at Bicêtre Hospital. The liaison activity in perinatal psychiatry is included in a French national prevention policy for women and their babies. It includes early detection, assessment, therapeutic management, preventive measure of psychiatric disorders. CL Perinatal Psychiatric Team work in close collaboration with multidisciplinary specialists, pediatricians, gynecologists, obstetricians, neonatologists, nurses, psychologists, and social workers. Team composition is likely to reflect available resources and specific need in the territory. For the patient, team working with interdisciplinary approach tend to lower the stress linking to the psychiatric aspect of the consultation and reduce the stigma related to psychological or psychiatric issues. In France, several professionals compose CRPP team. Perinatal consultant psychiatrists and perinatal psychologists may be supported by nursery nurses or specialized nurses, junior psychiatrists, specialized nurses, or midwife specialized for addictions. They may be practicing in different wards, including maternity, neonatology, neonatal intensive care. Maternity ward of Bicêtre Hospital is a tertiary maternity ward with about 3,500 deliveries per year, including an orthogenic unit for women in need of contraception or to perform abortion up 16 weeks, and the Women's House, specialized center for women victims of violence. At Bicêtre Hospital, CL Perinatal Psychiatry team is composed by perinatal consultant psychiatrist, junior psychiatrist doctor in training, while maternity team is composed by obstetrician and pediatrician, child psychiatric team, perinatal psychologist, midwife specialized for addictions, care coordination midwife. Indication for consultation are depressive and bipolar disorders, anxiety disorders, obsessive compulsive disorders, acute stress disorder and PTSD, psychotic disorders, severe personality disorders, pregnancy denial, medical termination of pregnancy for psychiatric and psychosocial reasons. Consultation requests are arisen exclusively from maternity care staff during the pregnancy and the postnatal period, only for inpatient women at the maternity unit with past or new mental disorders during pregnancy and in the postnatal period, without any psychiatric follow-up or with interrupted psychiatric follow-up or requiring expertise in perinatal psychiatry. The role of CL psychiatric perinatal team is to assess mother's psychiatric condition, share decision-making about the risk and benefits of treatment options, the risk and benefits of breastfeeding for the mother and the baby, evaluate the effect of psychotropic and psychoactive substances taken by the mother with the pediatrician, mother-infant interaction assessment. For co-parent, to assess co-parent's mental health condition, support partner-infant interactions. For parent, assess parenting ability, refer to different type of joint parent-baby care, if necessary, like home parent-infant units, the hospital parent-baby units, mother-baby units. Evaluate the support of family within maternity team, promote collaboration between teams members, including social workers and medical personnel. Also improve quality of relation between the different teams. Enhancement of interpersonal skills in each caregiver. In France, antenatal integrated perinatal care, including screening for psychological or psychiatric disease with a general practitioner, gynecologist, or a midwife, the early prenatal interview. So the woman can be oriented to psychologist or psychiatrist at Bicêtre Hospital in case of severe psychiatric disease. The coordination midwife in the maternity ward is informed, and a consultation with the CR perinatal psychiatric team is organized. Then the case is presented during multidisciplinary staff. In the multidisciplinary staff, CRPP team identifies the clinical needs of the mother and the baby. It tailors an adapted care pathway through networking with the health professional in the area. It provides key elements to understand the perinatal psychiatric disease and the consequence for the development of baby and the mother-baby relationship. It evaluates risks, including suicide, in relation to the pregnancy and any potential risk for the child, in order to decide a protocol to follow at childbirth, postpartum, and for breastfeeding. When needed, the CLPP team can require a longer hospital stay at the maternity to provide a safe environment of care before returning home. In situation of violence, it refers the woman to the women's house for elaborate and social and care pathway. In the situation of medical termination of pregnancy for psychiatric or psychosocial reasons, the PP team evaluates the woman's mental health and legislative context. In case of severe decomposition of psychiatric disease in antenatal period, a hospitalization in another adult psychiatric mental health service is organized to later integrate a perinatal psychiatric care pathway. In the postnatal period, if necessary, the CLPP team could decide to the separation of mother and baby, still with the goal of later continuing the care in a mother-baby units as soon as mother's mental health condition allow it. In case of severe relapses of psychiatric disease, it's important to support the co-parent and the family, as an example by explaining a perinatal psychiatric option of care and the possibility of joint parent-baby care, but also by educating the family about mother's psychiatric disease. In the last year, consultation activity of the CLPP team at Bicêtre Hospital was characterized by consultation requests in large majority for perinatal depression. Over the last year, while we observed an increase of consultation activity, we noticed a reduction of consultation for severe decompensation of mothers without psychiatric follow-up. Although our sample is not representative of the general population, their findings suggest that the preventive measure implemented during the perinatal period may still have been effective. Thank you for your attention.
Thank you so much, Antonia. It was very clear too. Thank you very much. And thank you so much for respecting the time. So I will present our day hospital unit now. I share my my screen. That's fine. Oh no, sorry. That's fine for you?
Oui, oui, c'est bon, Charlotte.
Okay. There is. I'll take Vered. What do you think? I'll take 15 minutes and 15 for questions. That's fine for you?
Perfect.
Good.
Everything is so interesting so far.
Thank you very much. So I will present our parent baby day hospital, which is located in a psychiatry hospital in Poitiers. You can see here, Poitiers. Within the University Child Psychiatry Department in Poitiers in Western France. It is one element of a broader perinatal psychiatry service that also includes outpatient consultations and a full-time parent-baby inpatient unit, which is physically adjacent to the day hospital. So, as my colleague, yes. Our team is multidisciplinary. In France, it's like that. And we are open 5 days a week and can welcome up to 5 families per day. Families usually attend 1, 2, or 3 days per week, depending on their needs and treatment plan. Overall, we follow about 20 to 25 families per week, being embedded in a university child psychiatry service and in a structured perinatal psychiatry service allows us to work very closely with adult psychiatry, with maternity wards, with community preventive services, and with downstream child psychiatry units when developmental difficulties persist. So there are four many referral pathways. First, we receive referrals from mobile teams working in maternity wards. They identify mothers with psychiatric difficulties, as Antonia said before, severe distress or concerns about early interactions with the baby, and then orient them to our perinatal pathway, including the day hospital. Second, we work closely with community mother-child preventive services, the PMI, Protection Materno-Infantile. They do early screening for vulnerability, difficulties in parent-infant relationship, and social risk factors, and can then refer families to our perinatal security service and specifically to the day hospital. Third, families can be referred from within the perinatal psychiatry service itself. For example, they may start with outpatient consultations, and then we propose the day hospital to intensify the work on parent-infant relationship. Or a family may be discharged from the full-time parents-baby inpatient unit and then continue treatment with us as a step-down level of care. Finally, we also, of course, receive referrals from adult psychiatry services when the pregnancy or postpartum period raises specific questions about the baby and about the parent-infant relationship. The day hospital offers a space where we can work with both parents' mental health and the infant's development. In terms of indications, we like to present our work as having 3 entry doors. The first entry door is parental psychiatric disorders as a full-time mother-baby unit, which impact the parent-infant relationship. We see many mothers with bipolar disorder, borderline personality disorder, post-traumatic stress disorder, and various anxiety disorders. OCD a lot, and general on anxiety too. Where I am. Admissions are voluntary and must be compatible with the presence of the baby, of course, and of other families in a group setting. We constantly balance severity, safety, and the need to protect baby and other families. The focus is not only symptom reduction, but also how the disorder affects availability, sensitivity, and capacity to respond to the baby. The second entry door is difficulties in parent-infant relationship, even without a clear severe psychiatric disorder. These parents often have a traumatic life history, insecure attachment, or history of abuse or neglect. Becoming a parent can reactivate past trauma, you know that very well. The third entry door concerns early developmental or regulatory difficulties in the baby that impact the relationship. Intense crying, severe sleep difficulties, feeding issues, or early signs of developmental vulnerabilities. The focus is on interaction. How can we help parents understand and respond so that the relationships becomes more thriving and more organized? In all these situations, the co-parent has an important place, and you know we have a lot of works about it. Florence had done a lot of work about the mental security state of the co-parent. The co-parent can be co-hospitalized, attend consultations, or receive individual treatment within the perinatal psychiatry service. We systematically try to involve them to support the baby, to share mental load, to contain crises, and to help the family function as a whole. I will now describe a typical day in our unit. Our day starts around 9:30 when families arrive. The morning is centered around group and interactive activities, always with the babies present. We offer various mother-baby or parent-baby group activities such as yoga, massage, stroller gym, hydrotherapy, and dance therapy. These activities are not just recreational, you know, too. They promote body awareness, relaxation, pleasure, and shared movement, and non-verbal communication. For example, in mother-baby massage, we work on how the parent looks at the baby, talks to the baby, and adjusts their touch to the baby signals. We also run psychoeducation groups on emotional regulation for parents, where we explore intense emotions, early warning signs of relapse, and strategies to ask for help. And groups on infant development, where we talk about crying, sleep, and very practical questions like, what can I actually do with my baby during the day? We try to normalize common concerns, give simple tools, and reduce guilty and feelings of failure. We also provide information about social support and financial benefits with our social worker. Alongside these structure groups, I have time, yes. There are many informal therapeutic moments, our toolbox times. There is floor play with toys and games where staff support the parent in observing the baby's initiatives and finding pleasure in shared play. We work a lot on parental sensitivity, reading infant cues, distinguishing different kinds of crying, noticing signs of fatigue or overstimulation. We avoid doing things instead of the parent, which is the cue of our care. We support them in doing it themselves to build that sense of competence. We also use swaddle bath, which can be very containing and soothing, and shared meals, which build group belonging and allow many small interventions. In the early afternoons, there is usually a nap time for both parents and babies. Many mothers, you know that, are exhausted from insomnia or from the demands of caring for the baby. Offering a safe space where they can rest while knowing their baby is cared for, can be very therapeutic. The afternoon is then dedicated to individual appointments. Depending on the needs, parents can meet with the perinatal psychiatrist, the psychologist, or the occupational therapist. We may have individual psychotherapy sessions, medication reviews, dyadic therapy sessions, or developmental assessments for the baby. We also organize regular multidisciplinary team meetings and case reviews to discuss each family's progress, risk factors, and treatment goals, and to adjust the care plan. Finally, there is a strong collaboration with the wider professional and family network, PMI, childcare providers, adult psychiatric teams, and child protection services when needed. We sometimes organize family meetings, including grandparents, when this can support the parents. In terms of discharge and follow-up, many parents are oriented back to adult psychiatry services once the acute perinatal period has been stabilized and the parent-infant relationship had reached a more secure level. They may also continue with outpatient consultation within the perinatal psychiatry service, with a lower intensity of contact. If the baby's developmental difficulties persist or new concerns emerge, we refer them to child psychiatry services, for example, to the Denver unit in our setting. To finish, I would like to briefly mention some of the main challenges we encounter in our day hospital. One important issue is that suicidal risk is often present in the mother we see. Sometimes when the risk is too high to be safely managed in a day setting, we have to organize a transfer to adult psychiatry or to the full-time parents baby unit, but we have only 3 beds, 3 rooms. This means we constantly reassess risk, maintain close communication with adult psychiatry, and try to ensure safety while still preserving as much as possible the parent-baby link. It's hard. Although very specialized, we make a point of not forgetting the baby because we are sometimes overwhelmed by the mother issues, and it's a big deal. Another major challenge involves neglect and child protection concerns. When we are seriously worried about the baby's safety or well-being, we may have to send a report to child protection services. The following processes can be long, complex, and their outcomes uncertain, which is difficult both for the family and our team. We have to hold together a protective stance for the baby and an empathetic, supportive stance for the parents. It's hard for the team. We also face discontinuity of attendance. Babies are often ill with viral infections, and some parents have difficulties engaging consistently with treatment. I see very well. Yes. This can interrupt the therapeutic process and make it harder to build a stable attachment to the service. So we need to be flexible to re-engage families when they drop out and to clarify expectations about attendance. This brings me to another key point, the need for a clear therapeutic framework. Because the day hospital can feel very containing, sometimes almost family-like. It is important to define and regularly review treatment goals with the parents. We try to avoid the situation where the goal becomes simply staying at the day hospital without a perspective on change, autonomy, and life outside. Related to this, we sometimes observe very long stays. Some mothers settle in and find in the unit what they describe as a tribe, a group of peers, a safe place, almost an identity. This is understandable and in many ways positive, but it can also make it difficult to move on. So we tried to think early about the other spaces and relationships in parents' and babies' life, and we support them in reconnecting with the outside world. Finally, involving the co-parent remains a challenge. Even though we systematically offer appointments and try to create a real place for the co-parents, their attendance is often fluctuating. Work constraints, separation, their own psychological and psychiatric difficulties, or social and cultural factors may limit their involvement. We are still thinking about how to adapt our schedules, our interventions, and our messages in order to truly include co-parents as partners in care. I'm a little bit tired to speak in English so a long time. To conclude, our Parents Baby Day Hospital in Poitiers is a small but very intensive and relationally focused unit, fully integrated into a broader perinatal psychiatry service. It allows us to work at the intersection of parental mental health, infant development, and the early parent-infant relationship with a strong emphasis on group support and multidisciplinary collaboration. Thank you for your attention. I will be very happy to answer any questions with the help of Ferret or discuss how this compares with your own services. Thanks a lot for your attention.
Wow, Charlotte and all your group, this was so impressive, so interesting and inspiring. I have written like a million questions, but I'm going to hold on to them. I'm going to let others start. We're not many people, so whoever wants to ask anything, please open your microphone and camera. If not, I'm going to start asking, and that's not going to be good because I have a million questions. Since nobody's asking, I'm going to start with I have so many questions, but I'm going to start with one that's for all of you. This is very impressive what your government has allowed you to build. I think many people from other countries struggle with building these services and especially the continuity of care, which is so impressive and so important. I think one of the most important graphs you've shown, I think it was, well, I can't say the names, but when you spoke about the liaison, that the amount of severe cases has dropped in the liaison service. That is very impressive. It's because of your capability to do preventative work. But I wanted to start with a question. I think in most of most countries, most of the world, people leading perinatal psychiatry are adult psychiatrists. And I think in France is very different in the fact that it's led by pediatric psychiatrists. So I would love to hear your thoughts about it and how you see this different path.
And now, do you want to answer?
The question, it's a problem for an everyday problem, I would like to say. We are on the screen, you have child psychiatrists, but you have also adult psychiatrists, Antonia, Florence, and I used to work in adult psychiatry for a long time. So it's a mixed practice, and you have to be a very good adult psychiatrist, but also a quite good infant fetus psychiatrist. So you can come from both sides. And for the, I don't know if you know, but in France, the residents have a special option in perinatal psychiatry and can get a specialization on perinatal psychiatry since last year, and then can do that even if they are a child psychiatrist or an adult psychiatrist. So we are at the cross section of the two specializations. So that's a nice question, and I think we have to go on to be a real specialty. Something we are doing something different from adult psychiatry and different from child psychiatry, really.
Yeah. Yeah, that's true. I think in many states you don't have a subspecialty in perinatal psychiatry. We are on the edge of forming this subspecialty in Israel, but we have only we will be only allowed to teach adult psychiatrists. I think that's a shame. I think
Yes, that's a shame.
Maya, okay, sorry. My daughter is flying out. She just came back from Bordeaux. From from Olympics in math, and now she's going to Hungary for an Olympics in computer science. Never mind. Okay, so anybody else more questions? I think that's very interesting. I have other questions if nobody wants to ask. I think somebody wanted to ask about the diagnosis.
Yes, about OCD and anxiety. Roxanne?
So if nobody else is asking, I'm going to ask Charlotte about your day unit. You said a few things that were that I had questions about. You said people can come once or 3 times a week. So I was wondering, how do you decide how many times they come? And also your group is very diverse. I wonder how you manage a group with a woman with a bipolar depression and a woman that's only dealing with severe cry issues or feeding issues with no psychiatric diagnosis. How do you work in group sessions with so different populations?
For your first question, at the beginning of the hospitalization, it's two days per week because they have a lot of symptoms. And step by step, we can load the days during the week. Okay. And the other questions about it's
But then the group changes every day? Like you're open.
yes. The group change every day. Yes. Sometimes some women can meet another if by chance it's the same second day, but it changes all day. Do you understand? That's fine to you.
Yeah, I understand.
Other
I think
presentation.
Yeah, no, I understand. And still they feel like they have a tribe. That's very interesting.
Yes, of course. Yes.
And perhaps in the hospital, we are working on mother and baby link. much more than on maternal psychiatric pathology. So it can be a lot of different psychiatric pathologies, because the problem is the link and not really the pathologist. I don't know, Charlotte, how it is, and Ludivina,
Yes,
but
we have the same model. Mm.
they have an adult psychiatrist for the mother.
Yes, I agree. The group can function, can work even if there is a lot of different pathology, because the aim is a baby, in fact.
And the adult psychiatric symptoms are not severe when you come in the hospital.
Mm-hmm. How many women come after they've been in a mother-baby unit, in a full-time mother-baby unit?
In the day hospital,
Mm-hmm.
Je dirais à Poitiers, all of them. After, if they live in the department, after mother baby unit, they come at the day hospital. That's your
So
question?
do all moms from the mother-baby full-time unit continue in a day unit?
Most of them, yes.
Most of them. Mm-hmm.
In Poitiers, I don't know in Bordeaux for Anne-Laure, but in Poitiers or in other.
In Bordeaux, it's, I think, like in Poitiers, Charlotte, because it depends on where they are living. Because mother and
Yes.
baby unit have a regional territory. So sometimes they can live very far from the place where they were hospitalized. And sometimes they have their hospital not too far from them, from their home, but sometimes not. So it depends.
It depends where they live, but if they live near, they come.
Okay. Okay. Um, do you sometimes hospitalize a father?
Tu veux répondre, Florence, ou alors non. No,
No.
Not in Bicêtre University Hospital, but there are in France some units who could offered bed for the father. But in Bicêtre University Hospital, Antonia has only a group for the father, and he could come all the day, all the afternoon if he wants.
Without sleeping.
Without sleeping, but
sleeping.
there is one unit in Paris that could offer a bed for the father.
And in
And I
Poitiers, in Poitiers, in our inpatient unit, we can have the father who sleeps.
Okay, in a full-time ward.
Yes, in our
How
full-time ward. And it's really helpful for some families. Sometimes it's not a good idea because there is a rivalry between father and mother. Sometimes there is violence, so it's not a good idea. But sometimes it's really helpful. When there is a good collaboration between parents, it could be really so helpful to have the father with us.
and could you hospitalize a father-baby
Yes,
pair?
and Lars said yes too.
That's what I wanted to say, because sometimes it can be very interesting to do that. Because when the mother is too ill and the father a little bit depressed and not able to be alone with the baby and needs help, we did that once. And it was very interesting. We are doing that a lot in day hospital.
Yes.
Yeah.
I'm not sure I understood. My question was, if a father, let's say a father has postpartum severe depression, the mother is fine, the mother is not ill. Can you hospitalize a father baby?
That's it.
That's it. But in Bordeaux, it's more frequent when the mother is very ill and cannot be hospitalized with the baby, and the father is depressed also. And so we hospitalize the father and the baby. And after that, we change, we take the mother.
And how does that work in a mostly feminine ward.
Fine.
When
Very fine. We have to reflect with our psychologist about that because it's not evident. But finally, when you give a place to the father and the team is okay with that, it's really helpful, and there is no problem. We have before we had a lot of fears about that, but it's fine. Finally, if we are okay with that.
very impressive.
In the maternity, it's complicated because fathers can't be hospitalized in the maternity. Sécurité sociale cannot pay for that. So they are here, but like outpatient, and we can take care of them, but like outpatient, it's but they can stay even alone with baby when mother is hospitalized in adult unit, for example.
Even in your unit,
Yes,
that's in the
even
maternity
in
ward.
maternity, but it's a war. It was
Big
a combat.
fight. Big
We
fight.
fight for that. Thank you, Charlotte.
And actually, your unit, the unit in the maternity ward, it's more like a preventative unit, if I understood correctly.
But, yes, but sometimes there is very early symptoms in anxiety, OCD, depression before childbirth, and early difficulties in the relationships between parents and baby at the beginning, just after birth. So, yes, preventive or not.
Well, if I understood correctly, most of your patients are assessed antenatally before
Yes,
childbirth, and then they give birth, and then they are hospitalized in your unit. So that's why I say preventative, because
yes.
you
Yes, but we know them before birth. We have a consultation unit in the maternity too. So in the most of the case, parents are seen in consultation before birth, and we have a lot of severe personality disorders, etc. So yes, it's preventive care for the baby, but for the parents, we begin during the pregnancy, in fact.
So what do you do during the pregnancy? What's the intervention during pregnancy? And does it sometimes make the postpartum hospitalization unnecessary?
Yes, we follow them in consultation in another unit, but in the same maternity. And I work in both units, so it's simple for me, you know. And sometimes
You are the continuity of care.
yes, yes, and sometimes and my social worker too, and we work with a lot of outside social workers and PME, and sometimes we prepare the hospitalization, but it's not necessary, in fact, and sometimes we not prepare that, and it's very necessary after birth. So.
But basically, you can't hospitalize in your unit acutely severe patients like a postpartum
No,
psychosis.
no, not too severe because we are in the maternity, in the
Mhm.
postpartum maternity, so it can be dangerous if it's too severe.
And then you say it might be an instance where the father is with the
Yes,
baby, the mother
yes,
goes to general psychiatry, and then she can come back.
yes, but like it's a short hospitalization,
Mhm.
in reality, not often.
Not often.
Mm.
So
After we address the family in a day unit, like Charlotte units.
Mm-hmm. But in France, can a woman be hospitalized involuntary in a mother-baby full unit?
Alors,
It depends on units. Some can do that, some other doesn't want. It depends also, I think, if you are in an adult ward or in a child psychiatry ward. In adult ward, it's not a problem. In child psychiatry ward, it's most difficult because people are not aware of that and they're afraid. I don't know, Charlotte and Ludivine, what do you think? I know that Florence, if you want to say something, you are doing the same.
There is no involuntary admission in Bicêtre University Hospital in all the departments.
We don't have to. We don't have, but we are child psychiatry unit, and I say like Anne-Laure, my team will be very, very anxious if we have involuntary hospitalization.
And in our unit, we can't separate adults and babies, or not for a long time. So we think it's dangerous for the baby if parents are too sick.
Mm-hmm. Mm-hmm.
The problem of involuntary admission is that it can be for suicidal thoughts or things like that. Of course, if you have disorders, very bad disorders, very severe delusional disorders and so on, we don't take the mother. They first go to psychiatric aid or psychiatric unit after they come. But with suicidal thoughts, it's possible. Or with hypomanic or soft manic episode, you know.
Okay, this has been a very, very interesting hour and a half that you all spoke in fluent English, although you were so scared of it. You all spoke very clearly. I think much better than I would do for an hour and a half, of course. Thank you so very much. This was fascinating and so much to learn from. And have a great evening. And thank you, everybody else that was listening here. And if you have questions, I think you can send us. And I'm sure the French team will be happy to answer.